everyone, we're back with another video in our 25 days to question your induction series. Today again I'm going to be reading from Why Induction Matters. I'm not going to get into too much detail with what the complications and variations are, because we do talk a lot about that on our site. We have lots of information. You can look it up yourself of what these complications are. But I just wanted to go into what it means in regards to induction. So in our last few videos, I talked about the statistics for all of BC and all of Fraser Health. I talked a little bit about our very, very high induction rate in Abbotsford Regional Hospital. 31.9% is way, way too high. It's higher than the rest of Fraser Health. It's higher than the rest of BC. It's higher than BC Women's Hospital, which has all of the high risk cases of pregnancy. So you would think that a high risk facility would have a higher rate of induction than Fraser Health or even for Abbotsford Regional, and that is not the case. And when you look at the numbers that it's for pre-labor rupture of membranes and post-dates pregnancy, it makes it even more concerning. And so the purpose of these videos is to get the information out to you, the consumer of maternity services, so that you can make informed decisions about your care. We know that midwifery care offers more likelihood of you getting full informed consent. They just have more time to sit with their clients and discuss the risks and benefits and alternatives. Whereas obstetricians, they're busy guys. They deliver so many more babies. They have so many more clients, and they usually only spend about 15 minutes at your appointments. They don't have time to answer the questions. They should, but that's just not the case. We have a lot more people having babies than we have care providers to take care of them. And part of that has to do with the funding of the hospitals. They don't have enough money to hire more providers. A little bit of it has to do with how the universities can't get enough people through. I know that I think the BC College of Midwives only has about 20 seats for a class per year. I think that's what it was. I had that on the page a while back, but we're not getting enough midwives in to cover the retirement of the family physicians, and then the obstetricians have an workload of low-risk women, but they're going with their high-risk procedures because that's all they've really been taught. They haven't been taught physiological birth. So their main concerns and they're in pathology. They're looking for problems, and sometimes that leads to them recommending things that cause more problems, and then they say, see, you needed to be induced because now you had to have a C-section, when really it's you got induced and then you ended up in a C-section, and they don't tell you those risks that you could end up in a C-section. So until the system changes and until care providers who offer this alternative support are actually given the funding that they need to be able to do their job fully, it's going to be up to us to navigate maternity care. It's not fair. It shouldn't be that way, but that is what we're looking at right now, is we need to advocate for ourselves until the system can get the funding it needs to change, because without us, it's not going to happen. So, last few videos I talked about informed consent, and I talked about the framework of decision making and about brain. And if you haven't seen those videos yet, I encourage you to go watch them, because it is great for making any decision involving your care, either maternity or otherwise. And I encourage you to also pass this on to any other moms who may be induced. And I definitely recommend that you go pick up this book, Why Induction Matters. Order it online. It may come after Christmas. It may come after New Year's. It may come in February, but it's worth it. It's worth waiting for. This book is amazing. This book will change the way you think about induction and complications. It may ease some concerns you have. There's a whole chapter in here on intrauterine growth restriction, which I wish that when I was pregnant with my son, I had this book. I wish this book existed. I wish I had this information. Because if I had just read that one chapter, that little tiny section on IUGR in pregnancy, I would not have stayed in the hospital. I would have said, no, I'm having a home birth. Because if I had known what they say in that section, I would have known that there's nothing wrong with my son at all. And I could have him my way at home and not feel like this induction was looming over my head, or that if I ended up with a home birth, I'd get in trouble, because that's basically what I thought at the time. I didn't know I had the right to refuse. If I'd known that I had the right to refuse and that I could still get a midwife to come to the house, then that's what I would have done. But as a first-time mom and first-time home birther in my family even, I didn't really have a lot of information to go off of, and I didn't know where to look. I certainly didn't know about midwife thinking at the time. I didn't know about improving birth. I found all this information out after, when I was looking for it after I had my son, because I wanted to have a home birth with my second baby. She would be the one that would be my healing home birth. I was very determined, and the more I read, the more I got angry. The more I said, this is not right, this is not acceptable, we need to do better. And then I saw the rally out in the US for improvingbirth.org, and I said, I want to go to a rally here, and there weren't any, so I started one, and that's how this all started. So getting in back to the book though, it is incredibly important that we inform as many people as possible. I say people because it's not going to do good if we just inform the moms. We need to inform their families so that their families can support them. We need to inform their partners so that their partners can support them. Because if you have a partner, male or female, who is saying, well, you can't have a home birth, it's not safe, I read this, I read that, and you don't get the information to them, or you can't have you have to have an induction because it's safer. I hear that a lot from women's partners. It's like, well, you know, if she goes overdue, she'll have to induce. I mean, we need to do what's best for the baby. And every time I hear that, I just shake my head, because that's not what's best for the baby, and that's not what's best for mom. And that's how far our culture has become ingrained into this idea that if baby doesn't come by whatever arbitrary due date is given, that something's wrong and you have to induce. And then we end up with more C-sections, and then we wonder, well, why do we have all these C-sections? Well, that's why. That's why, guys. And I wonder, every time I look at the statistics for C-sections for first-time mom, I'm like, how many of these women were induced? How many of these women had their labors augmented? Like, they came in early labor thinking that they were in active labor, and they slowed down, and then they were put on the Pitocin drip, or their waters were broken. How many of them? Perinatal services is not saying it. We're trying to get that information from care providers, and they don't have it, or they don't want to give it. So you really have to be thinking critically about this and asking questions when you see the data and you go, okay, well, how many of these were this? I'm tempted to write to perinatal services, but we're going to get into complications today, and I'm not going to go too far into it. You should know by now, from what we talk about and what you read, what hypertension is and what pre-eclampsia is and what the standard is for that. So hypertension is different from pre-eclampsia. Hypertension can lead to pre-eclampsia, and hypertension can be present in other complications, and it can lead to complications. But hypertension is also, it can be normal for pregnancy, and you could have had high blood pressure before pregnancy. The way hypertension is measured is, for pregnant women, is the same way it's measured for regular people. If you go 30 millimeters over mercury. So it's like if you have like if you were like 100 over whatever, like, and then you go to 130, then that's concerning. So it says here, high blood pressure can occur during pregnancy in absence of any other problems. Some women already have high blood pressure, called chronic hypertension, before they become pregnant, and this may not be identified until they have their blood pressure checked in pregnancy. Other women develop high blood pressure in response to changes in pregnancy, and this is called pregnancy-induced hypertension. Most women with high blood pressure in pregnancy have otherwise healthy pregnancies, and sometimes high blood pressure can increase the risk of a complication developing. Or it could be that you have a complication and high blood pressure is one of the symptoms. So it could be a chicken or egg kind of deal. It can develop into preeclampsia. So that is why we need to monitor women that have higher blood pressure. There's two options in regards to induction. It says they can induce before complications develop. So basically a better safe than sorry approach. If you're one of those better safe than sorry people, that may be an option that you'd want to look into. If, however, you're the kind of person that's like, well, if I have this, but I don't have that, and I don't see the reason to do something when there's no actual problem, then induction may not seem right for you. Your care provider may be a better safe than sorry, and you may be the type that's like, well, I don't really feel the need to do this. Or you may have a care provider who is more relaxed and thinks, well, you know, we'll wait and see. And you could be the anxious one. And if you're the anxious one, then it is still your right to say, you know, I understand what you're saying, but I just would feel better to do this. And that is your choice. It says induction does not improve the outcomes to the baby if the mother has hypertension and is induced. So it would get rid of the high blood pressure, but it doesn't really it doesn't change the outcome. It doesn't really improve it. It is what it is. However, the second approach is to wait for the spontaneous labor, and NICE recommends, the National Institute for I can't remember the acronym right now, but basically it's their guidelines over there, kind of like the SOGC here. They said that 160 over 110, the timing of birth should be discussed. So it's like if you're at like 160, that's pretty high. But you have to take into account the whole clinical picture. So I'm not going to get too far into that. And they're just talking, they have stories in this book too about actual experiences from moms, and that's what's coming up in the next one. Pre-eclampsia is a big one. If you have pre-eclampsia, induction is definitely preferable to waiting, because pre-eclampsia can lead to seizures. It can lead to, it says protein leaks out of the blood vessels in the kidneys and it ends up being excreted in the urine. That's why they check for protein in the urine. It can cause problems throughout the body, resulting in additional symptoms including headaches, visual disturbances, pain in the liver. Even though preeclampsia begins early in pregnancy, symptoms don't usually appear until after 20 weeks. It also says here, complications are significant for both mother and baby. There's also a risk of hemorrhage with preeclampsia if you have a C-section. So even though induction increases the chances of having a C-section, and having a C-section at the end of preeclampsia could also lead to more complications, it's already a really complicated situation, and induction would probably be the best bet rather than just going for a C-section, because you may actually be able to birth the baby without having the C-section. And if you do end up with a C-section, they're already aware that there's going to be extra complications with this. The other thing is, it says induction of labor is recommended in the case of pre-eclampsia. The ideal timing of induction will depend on how severe the pre-eclampsia and the symptoms. They also usually give medication to try to lower your blood pressure before they induce, because they want to try and keep baby in until 37 weeks. But there's problems with blood clotting with preeclampsia, and that is why it is really a good idea to consider induction in that case if you develop preeclampsia. If you just have hypertension and you don't have protein in your urine, you probably don't have preeclampsia. If you have gestational diabetes and you've got protein starting to show up in your urine and you have hypertension, that could probably develop into preeclampsia, or it may not. But if you have been diagnosed with preeclampsia, that is not something you want to mess around with. That is one of the reasons why we have induction of labor. That's what it was originally for, was for these special cases. That's one of the 10 to 15% of cases that World Health Organization recommends for induction of labor. So that's one of the things where you basically weigh the risks and benefits. Diabetes, that can lead to the body not producing enough insulin or producing too much insulin. And that can change the shape of the baby. When they say that you're going to have a big baby, it's not just fat. It's the baby's shoulders actually get bigger. In a regular pregnancy with big babies, the shoulders aren't getting any bigger. So it's different than if you have gestational diabetes. When they say you should induce for a big baby, if you don't have gestational diabetes, it might be fine. But with gestational diabetes, there's a small percentage of women diagnosed with gestational diabetes that have undetected pre-existing diabetes. So you might have had regular diabetes and not known it, and then get diagnosed with gestational diabetes. So they test that out through antenatal testing, and it's not possible to know if you have gestational diabetes or regular diabetes until after the baby is born, and then you can be retested. If your blood glucose levels return to normal, you only had gestational diabetes. It says here there's a disagreement about the best approach to screening and diagnosis of gestational diabetes. In the UK, it's a little different than here. Here, they basically offer it as a routine screen for all women. In the UK, it's only some women that get this routine screening, either if they have certain risk factors or if there's glucose showing up in their urine, or if they have higher glucose levels. Here, I just want to point this out. You do not have to take the test if you don't have any risk factors and you don't see any reason to believe that you have gestational diabetes. A lot of doctors and midwives may recommend it, but again, every single test that is offered is offered. It's not mandatory. So if you've already taken a blood glucose test or you have no risk factors, and the idea of taking that glucose drink and doing the blood draw just doesn't seem worth it to you, and the possibility of being misdiagnosed with gestational diabetes is high with these tests. And then you'd have to take the 3-hour one to rule it out. You can say no. I said no. I did not do it. So I just wanted to let you guys know that. But if you do have risk factors or you had gestational diabetes before, that increases your risk of developing it again, and then it's more likely that you would want to take the test. So again, it's back to weighing risks and benefits. I saw no benefits and I saw only risks to taking the test because I knew that it would interfere with my ability to be able to birth my daughter the way I wanted. So I said no. And with my son, I said no because I didn't want needles, and I didn't see any reason to do a test when I knew that it would come up fine anyway. And I had no glucose in my urine. My urine samples were fine. So I said, well, I don't have any risk factors, so I'm not doing it. And baby's fine, healthy. But it says that in recent years, the range of what is defined as normal blood glucose levels has been lowered, and it's been resulting in many more women being diagnosed with gestational diabetes. So the numbers have changed too, guys. The incidence of gestational diabetes varies from 3 to 18%, depending on where the tests are being done and how they're being conducted. Determining the risks of gestational diabetes is complicated. The research into gestational diabetes does not distinguish between women with pre-existing diabetes and gestational diabetes. It's all lumped together in the research. It often combines the outcomes of women who are able to maintain normal glucose levels with those who did not. And what is known is that the complications associated with gestational diabetes are to do with the blood glucose levels. And it's not the diagnosis itself of diabetes. So if your blood glucose levels are fine, you may not need to worry. If your glucose levels are higher, then that's when you would want to consider treatment. The treatment of gestational diabetes aims to keep the blood glucose levels within normal limits by diet and lifestyle changes. So if you're, again, taking care of yourself during your pregnancy, you may not need to induce. But for women with abnormally high blood glucose levels in pregnancy, it increases the chance of a number of complications. This is including pre-eclampsia, excess amniotic fluid, postpartum hemorrhage, and infection. In addition, women who have gestational diabetes are more likely to develop type 2 diabetes later in life if their glucose levels are abnormally high. And it can affect the baby. The baby increases insulin. High levels of insulin in the baby's body stimulates the growth of organs and fat stores around the abdomen and the shoulders. Large shoulders can increase the chance of baby having difficulty getting through the pelvis. They don't have any numbers here, so it's possible that there were no numbers listed in these researches, and I would like to know what the actual numbers were. If I could track down the studies, I would, but some of the studies are closed, and others are they're hard to find. I could probably even email Rachel and see if she could pass on some more information, but for now this is what we have to work with, and you're again welcome to pick up this book. Let's see here. There is the complication. These are less common complications, such as premature birth and respiratory distress syndrome. However, these complications may be associated with the early induction because baby's lungs haven't developed yet enough. When baby's ready to be born, there's a surfactant in the lungs that help the lungs to open. Until that surfactant is there, contractions don't get triggered. So if that happens and baby is born too soon by mechanical or chemical means or by C-section, that could be a reason why babies that have those problems are more likely to have respiratory problems, because the surfactant in their lungs was not produced at the time before they were born. So the other thing that it says here is that it's very common for baby's own glucose levels to drop after birth. And while this adjustment takes place, I just want to mention this. Babies may look jaundiced. Colostrum has very high levels of glucose and can help stabilize baby's blood glucose without the risks of formula. So instead of formula, you could give colostrum. But formula can also help baby, but the colostrum that has the higher glucose levels in it. If you're induced and you're able to have a vaginal birth and you're able to breastfeed without any problems, then breastfeeding is going to increase the chances of getting rid of the jaundice faster than if you have to formula feed because you've had a C-section and baby wasn't latching and all these other issues that can come up. So if you do end up with a C-section, try to get skin to skin in the OR. Because if you can get skin to skin in the OR within the first hour, baby may have easier time latching unless they're really, really young. Like under 37 weeks, they may have trouble latching. Keep at it. Pump colostrum, express it into a syringe, and try to give it to baby that way. If breastfeeding is important to you, that is something you do need to consider with induction and with the cesarean, because those two things can mess with the oxytocin levels that your body naturally produces, and it can cause problems with breastfeeding. So that is just another one of those risks that you kind of need to be aware of. So here's the part that everybody's really scared about, is the stillbirth rate. So long-term risks, some studies have suggested there's an increased risk of stillbirth for women with gestational diabetes. However, a recent Cochrane review found no stillbirth among a group of 425 women with gestational diabetes. So that's more than 100 women, which means it's less than 1%. And there were 425 women and no stillbirths with gestational diabetes. The Cochrane review also concluded that there is an insufficient evidence to demonstrate differences in outcomes for women with gestational diabetes and their babies if they have their labor induced or wait for spontaneous labor. The poor quality and quantity of research about gestational diabetes has led to varying recommendations about induction. So, induction rates may vary from hospital to hospital depending on which research the individual care providers are going by when it comes to women that have gestational diabetes. And when we went over the Fraser Health statistics, I believe I said it was 16% of women end up with gestational diabetes. 16%. So it's not even that high. It's not even 20%. And I think it was 12% or less that I said that they actually induce for gestational diabetes. So that's not contributing to our numbers for high induction rates. It says here, NICE, United Kingdom Guidelines, recommends that women with gestational diabetes should be advised to give birth before 41 weeks and be offered an induction to achieve this. In contrast, the World Health Organization recommends that induction of labor not be offered for gestational diabetes unless there's evidence of other abnormalities occurring. So they say don't even bother inducing at 41 weeks if everything's fine. Wendy had gestational diabetes with her VBAC 3C. Her vaginal birth after 3 cesareans, her baby. She had it diet controlled and she took care of herself and she was able to have a VBAC, and that was past 41 weeks. That was like, I think 41.5, I think she said. 41.4 or 41.5. But she's a 42-week gestation. It's typical for her. And she had a VBAC, and her baby was, again, smaller than mine. So she didn't even have a big baby compared to my 7-pound, 13-ouncer both times. So again, looking at the evidence, it says that if there's no problems, you don't really need to worry about it unless you're worried yourself. Now, pre-existing diabetes is a little different. I wish I could get into that today, but I can't. It's already 29 minutes and I need to go. So I will catch up with you again next time. Check out Midwife Thinking, pick up this book, read our stuff on induction, go back and check out our posts. I'm going to be reposting them because I'm having a hard time finding the hashtag for last year's stuff. on my mobile device, and I know a lot of people aren't using a computer, they're just using their phone. So I'm going to be reposting that stuff along with these videos, so then you're going to have a long list of information on induction. And I just encourage you guys to keep asking questions, keep looking at the stats. Go on to Perinatal Services BC's website. It's fascinating. If you love numbers, it is a fascinating thing to look at the different health authorities and see where they compare. And you may start to question what's being said in the media about why we have these high rates. Because a lot of the time they say, oh, well, the rate of cesareans going up because we have older moms, older, less fit moms, less healthy moms. And when you look at the demographics, it's moms that are under age 35. And the 20-year-olds and 19-year-olds are ending up having C-sections at the same rate as everybody else. And they're having inductions at the same rate as everybody else. It's not just the older moms. The older moms have a higher chance of having a C-section, but they're not the majority of the population that's giving birth. So when you look at that, you start to question, well, what's really going on here? Is policy is being put in place and women are not being told their options. And that's why we're here, to tell you your options and give you that information so you can start to question it. And maybe we can help our care providers be able to give the care that they really want to be able to give, but may not have the resources or the time or the support from their health authority to be able to do it. Because we got a lot of great midwives out here, and I'm sure we have some OBs out here that are also looking at the numbers and being like, well, I don't really agree with what is going on and what I'm being told I have to tell these women to do. Because I know that they didn't get into this just to bully women. They got into this because they wanted to help people. And it's the system that needs changing, and the system will change if we keep getting louder and saying, look, this is not okay anymore. We're informed. We're not these silly little women sitting at home and just going to listen to whatever anybody tells us. We're not the don't you worry your pretty little head about it. Everything will be fine if you just close your eyes and just do it for your baby. It's not going to work anymore. Healthy baby is not all that matters. A healthy mom matters too. We have a high rate of postpartum depression and birth trauma, and it does not need to happen. So, see you next time, and have a good day, guys. Bye.